Good afternoon, everyone. First of all, congratulations for organizing this conference and creating awareness amongst the people regarding PRP and stem cells, and it is the need of the hour. I will be speaking on stem cells today, and first of all, I pay my tribute to Dr. Shankar Narayan, who is my mentor, and Dr. Ravi, without whom I would not have been able to do this since 2015, what I'm doing. So stem cell and infertility, we know 17.5% people affected, and there are patients who don't have poor good quality eggs. What are they advised? They're advised donor eggs, but they want to use their own eggs. So what next? We know that men can produce sperms every 2 months, but females are born with a set number of eggs, and by the time they reach 40, 43, the number of eggs go drastically down, the quality reduces. So is there a role of stem cells? Let us learn that. We know that in all other aspects we can use, but what about reproductive? So I am going to concentrate on stem cells for ovary, where I am going to say diminished ovarian preserve with advanced age, premature ovarian insufficiency. Lots and lots of girls are coming with low egg, low AMH right now. Then there is fertilization failure. The embryologist says everything is good, the quality of the egg is very bad. Recurrent miscarriages where we don't see any other reason but the quality of the egg with low AMH. And also I'll be speaking on endometriosis and polycystic ovaries and reversal of menopause. So all this time we believe that there is a fixed primordial pool. Once you are reaching perimenopause, it's all exhausted and you won't have anything. But now we have isolated ovarian stem cells, and these are the ovarian stem cells we'll target, and folliculogenesis is the most important thing to get a good quality egg. Normally they remain in the primordial stage to avoid the depletion of the eggs. But then it's activated and you get a mature follicle, and this is the folliculogenesis. This you can see surrounding here on these are the oocyte, the oogonia, which are the dormant oocytes which we need to activate. So what will rejuvenation with stem cells do? It can create competent oocytes and not only restore fertility but also give good amount of hormones to that patient. We should understand there is something called as ovarian stem cell nest and stem cell niche. So here the nest is composed of this, and granulosa cells are the most important to get a good quality egg. And these is all the part that contribute to the stem cell nest, which is very important for the folliculogenesis. So you can say there are yellow ones are the ovarian stem cells which are there, the granulosa cells are the green ones. So the relevance of this niche is very important to restore the ovarian function. PRP somebody said, but I'll go further now the stem cells. We know that stem cells can differentiate into immunomodulatory, antifibrotic, folliculogenesis and regulation of angiogenesis once they home into the tissue where it starts going into its own cells or improving it. And the most important is the granulosa cell to get a good oocyte. It will reduce the apoptosis and apoptotic procedure will start, giving us a good quality of egg. So it may not increase drastically the number of eggs, but it will definitely improve the function of the eggs and delay the ovarian consensus. That is what we want to target. So how are the patients that we are going to select in any age group, but at least 40 is our cutoff. We go up to 45 years of age. Then it should have a patient should have a normal karyotype. Young patient with low ovarian reserve may have abnormal karyotype. And we should also see there is no autoimmune disease. Though we have started for autoimmune disease, because 2-3 months they can have an effect, and other comorbidities should be ruled out. It will migrate to the injured tissue, improve the granulosa cell, reduce the damaged microenvironment, and help increase the good T helper cells. The TH1 and TH17 go down, Treg and TH2 go up, and these are number of papers. Multipotent cells, what we are allowed to use in India, and that's what we use, and we use the bone marrow derived stem cell. We know that there are no ethical concern, limited immunomodulatory, low immunogenicity, and chemotaxis. We inject it transvaginally under ultrasound guided or laparoscopically. How do I start the video? So when we take the patient, we have to find out the size. At least the stem cells should be at least,
Click on
there's
video.
a video, 2 ml we try to inject in both the ovaries. And we also see that the ovaries are accessible. We don't allow the spillage, very slowly we insert it inside. But I would prefer to inject the stem cell laparoscopically because the ovaries are very small. You cannot even sometimes locate on ultrasound. Previously we used to do this, there was leakage. Now we are doing only 2 punctures, hilar and dehilar, and we see that the ovary gets blenched. So these are the procedures. Okay, so the next slide I'll go. Here, these are some of the cases which I'll represent, which have been done PRP, not responded. They're the worst cases where they've advised egg donation. Female, 30 years, 0.09 AMH, 14 FSH, which is very high. We did this stem cell therapy. After that, we tried IUL, and she conceived and delivered a healthy baby. This female, she's an American, she is STD positive, her AMH was 0.49, nothing was working for her, BMI was really high. We did this procedure, we called her after 3 months, in December meeting, 24 April she comes, we did IVF, only 3 eggs, one good quality embryo, and she delivered a healthy baby, because the quality is what that we want. Another female, 32 years, suddenly her AMH dropped from 2.8 to 0.25, which was seen in some females in COVID. So she had 2 cycles at our center, both high quality low, negative result. We told her to do this procedure of bone marrow derived stem cell in January 2022. May we did divorced it, 1 frozen embryo, blastocyst transferred, healthy baby delivered. Again a female of 39 years, 25 years married life, 11 IUIs, only 1 ectopic pregnancy. Her AMH was 0.862. IVF cycles were failing, they were advised donor eggs. They came to us, we did this procedure, then we did our IVF. In the second IVF, we got a positive result and she already has delivered a baby boy. Now, when the patients come with recurrent miscarriages, that AMH is very low. In these patients, also, when there is no other reason for recurrent pregnancy loss, like no anatomical condition or autoimmune disease, we go ahead and do this. She had 39 years, 2 failed IVF, 2 miscarriages, again advised donor egg saying that your AMH is low. We did this procedure, she was from US. She conceived naturally after this and delivered a healthy baby. 46-year-old living in US and Indian from Patna. She was advised the same thing. She had 4 miscarriages, including 1 Down syndrome. And she had 1 failed IVF, 1 failed IUI. The doctors in US said, keep trying or go for donor eggs. She said, before I try donor eggs, I want to have my own eggs. We did this procedure, November. December 31st, I get a message that I have conceived naturally. And then she delivered a healthy baby boy. So maybe the stem cell therapy can be extrapolating as a gene therapy. It's a thought for mind that we should be thinking. Now this is an unpublished data which we are now submitted to ASHRAE conference, where the low AMH patients have undergone ovarian rejuvenation with stem cells when there is no other factor, and out of 51 we had 27 positive, 24 delivered, though there was 11 patients who had miscarriage and the others are still trying. Now endometriosis, we know it's an inflammatory condition. People are worried that PRP or stem cells will increase it, but actually it's not so. Now the human and animal experiments have shown that stem cell based therapy can restore fertility in patients with endometriosis. Because it's an inflammatory condition, we want to suppress that inflammation with this. And this patient from Dehradun again had grade 4 endometriosis, 1 cycle failed, very low oocyte quality, go for donor egg was advised. She came to us, we did the lab surgery, you can start, and we took her bone marrow also in the same sitting. Once the ovary is clear, chocolate cyst, everything is removed, you can instill into the cortex beautifully the stem cells. And then we called her after 3 months to do her IVF. In January, we got 5 eggs, all 5 fertilized and good quality embryos, and she has delivered a healthy baby girl. And last patient from Delhi, 37 years, again 2 miscarriages, AMH was 0.15. She had chronic endometriosis, and people were saying go for donor eggs. We did the same procedure. We did the PRP as well as stem cells. Normally when we do stem cells, we also take PRP, and she also conceived naturally. Last is polycystic ovaries, which I'm going to talk of, which is again a very inflammatory condition in the ovaries. And here it has been seen that the human mesenchymal cell preserve the capacity to suppress the TH1, which is the culprit, and that may influence the internal inflammatory environment of PCOS. Very high AMH, 11, 12. What we do is, we take the stem cells, 7.7, a girl from US, LH-FSH ratio was 5.5, very, very high. Here we did only PRP, but we still insist to do bone marrow, and she conceived naturally and delivered a healthy baby. So far, the bone marrow derived stem cell therapy only for ovarian rejuvenation, till December 2024, we have finished 353 cases. Now, this is the stem cell unit at our case, you can play the video here. So with all this success, but what we were getting with the PRP, now we have switched mostly onto the stems in the required laparoscopy only. We went to develop our own stem cell base as per the CDSCO criteria, and with all the class 100, class 1000, class 10,000, all the stem cell manufacturing, working station, hematology, quality control, everything is done, entry with only biometrics. And here is where we have our own special units to manufacture the stem cells, and we are storing it also here. So this is the stem cell facility that we got. And this is because I say it's not a 100% success, but I say it's a 100% success for that patient who did not want to donor eggs and who wanted her own eggs, and she can get it after this treatment. That means it is a 100% success for that particular patient. So maybe all 353 patients will not benefit. Counseling is very important. But yes, when the PRP has failed, when everything has failed and they want their own eggs, this is the treatment that we should offer to these women, not only in low AMH, but also in RBI cases with low AMH, PCOS and endometriosis, but proper case selection, proper technology will be very important, and ultimately proper counseling. Thank you.
Okay.
Excellent work, fantastic. Everyone is well done.